Assalamu alaikum. Today we have a case of Pheochromocytoma around 5.4 centimeter in the left adrenal gland in a patient who is 24 years old, male patient, is a laborer by profession. We are mobilizing and medializing the colon. Here you can see this is the pancreatic tail, and that is the spleen. The more we mobilize the spleen from the diaphragm, the easier it would be to dissect the adrenal gland. Care is being taken here not to go more towards the kidney and not towards the spleen, because that was the area where splenic vessels will be going. And lower down, when we medialize the colon, we identify the ureter and the gonadal vein. Here you can see the gonadal vein very clearly, and the ureter can be seen as well. Remember, this is not an nephrectomy, so care must be taken not to injure the ureter directly or by thermal means, by using the cautery or the bipolar. Ureter is very sensitive to thermal injury, so care must be taken. So we have found the gonadal vein, and we have followed it, and by the location of the gonadal vein, we can now imagine where the renal vein would be. So the next step in doing an adrenalectomy on the left side is to identify the renal vein, and from the renal vein we will try to identify the adrenal vein. The main aim of doing this dissection in adrenalectomy for Pheochromocytoma is that we, before manipulating the gland, we have to immediately dissect the adrenal vein, and we need to clip it as soon as possible before manipulating the gland. As we all know that manipulation of the gland can lead to acute surge of catecholamines, leading to cardiovascular responses. So we place another port in the left iliac fossa for the assistants who can hold the medialized portion of the gut away from us, so that we can dissect the adrenal vein. Here you can see the adrenal vein is visible now, and we are trying to dissect it enough so that one clip can be applied. And once the clip is applied, in almost 6 to 8 seconds, the patient usually becomes hypotensive, and that is because of the loss of the tone in the vessels, especially in the vein in the intravascular compartment. So the anesthetist needs to be informed immediately, so that they can give fast and a lot of fluid to fill the intravascular compartment of the patient, so that he may not go into hypotension. So the adrenal vein is clipped, and then a bigger clip is applied towards the big vein, and another bigger clip is applied towards the adrenal gland, and then the adrenal vein is divided. You will see in a while that the moment this adrenal vein is clipped and divided, there is congestion of the adrenal gland and the small vessels around the adrenal gland. So once that has been divided, and the anesthetist takes control and gives fast IV fluids in a large bowl, bore IV cannula preferably, 18 size. Then we quickly try to mobilize the adrenal gland and separate it from the upper pole of the kidney. Remember, there is a branch which is coming from the upper polar vessel of the renal artery. So the renal artery is lying nearby. So dissecting this portion of the adrenal gland needs to be very careful, because there will be a renal vein and especially the renal artery. An injury of the renal artery is not desired at all, because this will lead to compromise of blood supply to the kidney, which is not the culprit in this situation at all. So the dissection on the medial aspect of the adrenal gland towards the kidney, here you can see that there's a branch to the upper pole of the kidney, and this upper polar branch will give an artery. Here you can see the pulsations very clearly. So here the dissection has to be done extremely carefully, not to use diathermy excessively, because the artery can go into spasm and the wall of the artery can be injured. You can see a lot of ooze on the surface of the adrenal gland, and the veins on the adrenal surface are getting engorged, and that is the reason, because the venous drainage has been blocked, and still there is arterial supply to the adrenal gland. So there are usually 3 arteries on the left side. The inferior phrenic artery gives a branch to the adrenal gland. Then there may be direct branches from the abdominal aorta, and there are branches from the renal artery. So our aim now is to mobilize the adrenal gland enough to expose the arterial supply of the adrenal gland, so that those vessels can be clipped and divided, and thus adrenalectomy performed. But here we are very careful, because a movement in millimeters where it cannot be visualized, the artery can get injured. So take your time and try to dissect the adrenal gland away from the renal artery. Here you can see very clearly that we are dissecting the adrenal gland, holding it laterally, retracting it, and dissecting on the surface of the adrenal gland. So we encounter a lot of small congested vessels. So there is a little ooze as well from those vessels, but the good thing is that we are staying away from the renal vein tributary as well as the renal artery. So we don't really bother about the small vessels which are bleeding at the moment. From time to time, you have to go to the upper pole to dissect a bit more, so that mobilization of the adrenal gland can be good. And then we come to the medial aspect. Here you can see that the small artery is coming. This one is the artery which is coming from the renal artery. So we clip it away from the renal artery, and then we burn it with the ligashore, a vessel sealer, and then we divide it. So some blood supply to the adrenal is now cut off, and we expect that the bleeding and the ooze and the congestion in the adrenal gland will now decrease slowly and gradually. So we are now sure that the gland has been successfully dissected away from the renal artery. Now comes the artery of the adrenal gland, which comes from the aorta. You can very clearly see the renal vein and the renal artery alongside it. So there is a little bit of congestion, and you can see a lymph node. So the lymph node is a sign that the artery will be around here somewhere, and there are some very small vessels coming and going from aorta. Some of them are lymphatic, some of them are small venous channels, some of them are small arterial channels, but we are looking for a bigger artery. So on the screen you can see with the arrow the position of the renal artery. We dissect away the small lymphatics with the suction, and then once the atmosphere is clear and the visibility is good, we are using the vessel sealer, the ligashore, to dissect the tissue around the adrenal artery. We can apply a clip to all the bunch, however we want to dissect it more clearly so that it can be visualized clearly and injuries to any other vessels are avoided. So here you can see that there are small arteries. One of them is bigger one, which is now clearly visible. It is going into the adrenal gland. So we use a bigger clip to clip both the arteries, and then we burn it with the vessel sealer, and then we divide it. And so the gland has now turned pale. All the blood supply to it has been stopped. The congestion is gone, the bleeding is gone, and now remains the upper portion. We expect to encounter inferior phrenic artery. However, using the ligashore can coagulate up to a vessel of up to 7 millimeter diameter. This is the normal portion of the adrenal gland, you can see. So that might be coagulated by the ligashore. We don't mind so long as it doesn't bleed. We know that mainly two arteries have been ligated and divided. The vein has been ligated and divided. So this is the area where there might be an inferior phrenic artery. And we rotate the gland upwards to see which area is remaining. This is the normal portion of the gland as well, and it is done. So after that we do the suction. We reduce the pressure to 6, and we see if there is any ooze or bleed. The kidney is beautifully pink, ensuring its blood supply. All the clips are safe and secure. And after doing a little bit of cleaning, and we place a drain through the assistant port, and the specimen would be retracted and extracted through the camera port. Thank you very much.